Hello everyone. Today I would like to show you a case of a true polar cataract which we did, and in this case you can see it looks like a true polar cataract. We made an elliptical axis, capsular axis, so that we had adequate chance of placing a three-piece IOL if required. We began by staining the capsule, and why I named this as a changing tides because it was of mixed fortune in this case. So we have already done a capsular access, and I do a hydrodilation. I didn't do a hydrodissection in this case. And I also did a viscodissection of the nucleus. Once I had done that, I directly entered the chamber by using my Otley OS4 phaco machine. I am in the phaco 2 mode, and my vacuum setting is around 450 mm of Hg. What I always wanted was to apply vacuum and I would be able to flip the nucleus, but this was not happening in this case. I was trying to flip the nucleus. I do think now retrospectively that a more hydrodilation would have helped me in achieving the flipping of the nucleus. After that, I did a mild rotation of the nucleus, but what you can see is that the whole of the nuclear epinuclear complex is rotating, and even during this, when I try to flip it, the whole of the nuclear epinuclear plate is flipping in one go. After that, at this point, I had noticed that it appears that the polar component along with the epinuclear plate has come, and the a PC rent has happened. I continue to do the phaco emulsification, hoping that might be the hyaloid will hold through, but as I see, the hyaloid is not holding through. I continue it with it, and at this point I feel that the strategy needs to be changed. So what I do is I wanted to use an IOL scaffold technique. At this point I did give another try of phaco emulsification, but as I see, the phaco is not coming adequately. So at this point of time I changed my strategy, did an anterior vitrectomy, and to remove the prolapsed vitreous. And once I have done a sufficient amount of vitrectomy, the plan was to put an IOL scaffold multi-piece which I had already which was already as a backup. So you can see the big PC gap which is seen. I put visco, and then I plan to introduce the IOL multi-piece IOL as a scaffold. Now at this point of time also, this is an Aurora multi-piece, and as you all know that it tends to rotate while you inject. So this also not went according to the plan. The leading haptic has entered the PC rent and has gone posteriorly. Now it's a double jeopardy. It can be that even the epinucleus complex can also fall, and also the whole of the multi-piece IOL can also fall into the vitreous. At this place I was into two minds how to go about. So what was my instinct was that I would just try to support the multi-piece, and since the nucleus was not that hard, I would complete the removal of the nuclear epinuclear complex which is in the anterior chamber in a jiffy. So that was the plan of action, and if it allows me, gives sufficient time, then I would be able to complete the rest of the maneuver. So might be the God was with me this time. I was able to remove the major chunk of the nuclear epinuclear complex without the IOL getting dislocated into the posterior chamber. After that, I went for a bimanual removal of the vitreous and the cortical matter by using the vitrectomy cutter with alternate on and off phenomena, as you can control. So I use the vitrectomy cutter itself to aspirate, and whenever required I use the same vitrectomy cutter to cut the vitreous also. So I am removing the, so now I can clearly see that the leading haptic is protruding through the PCA into the vitreous cavity. At this point of time, since the visualization has improved, I use an SFIL forceps to uh, to to reposition the leading haptic into the sulcus. So once I have done that, I use the vitrectomy cutter to complete the removal of the rest of the epinuclear plate. So the cortex can easily come, but the epinuclear plate takes some time for it to, for the vitrectomy cutter to come. So the cut rate is around 5,000 cuts per minute with a vacuum for around 350 mm of Hg. Alternatively, I also had to uh, use the infusion to accelerate this process by nudging, giving a few nudges. So once I have done that, there is a lot of cortical matter which is still remaining. So I go behind the IOL complex, and then I start removing it using the vitrectomy as an aspirator. I remove the remainder of the cortical matter. Also, when I go in between, I use the same cutter to also cut the vitreous. So the chances of excessive pull to the vitreous is obliterated. So as you can see, the vitrectomy cutter can beautifully help you in aspirating the whole of the, and the best part is whenever you feel that the vitreous is being nudged, is being engaged into the aspiration port, you can turn on the cutting mode and you can cut off the vitreous. And once you have done that, the central defect is further fashioned, that in case there is any opacity in the future, it doesn't obscures the central axis. Once you have done that, you use the same SFIL forceps to reposition the trailing haptic into the sulcus. After that, we can see that the excellent centration that we can achieve. Also, at this point of time, I use to remove few of the remaining cortical matter and give a final vitrectomy, using the vitrectomy probe to remove the whatever the remainder of the vitreous that has been prolapsed. So we do it, we can see the air bubble is freely mobile, so that is itself an indication that the vitrectomy has been done. I try to do an IOL capture, but somehow it is due to the asymmetric pressure difference, I don't think, despite my multiple tries, it is not getting captured. I put an air bubble, and the IOL is still in the sulcus, and as usual I put a suture the main port, which is one of the important procedures that to be done. Thank you for watching this video. Do subscribe my channel. Thank you. All the best.